We were one of the first SEOWs that was funded within a state that did not have one of the state incentive grants. And so we've evolved that process, and I and some of my staff have been very involved with the national kind of SEOW network in terms of looking at the indicators. And as we go through this, there's some things that I'll explain and talk about a little bit that are unique to small states like South Dakota and some of our challenges in regards to data. In one way, we have advantages, and in other ways, we have limitations and challenges related to data and explaining what the issues are. So hopefully that my preference is to do these types of presentations. And oops, now I clicked out of my screen. Okay, can you still see it? Yeah. My preference is to use these to do these presentations in person, but we'll do the best we can with a webinar. And if you have questions, how have you handled questions, Dodie?
Typically, we have them chat in the chat box.
Okay, excellent. And while we're doing that, I'm going to just click off my other programs that I have running on my computer so that we don't get interrupted throughout this. Let me click out of here. There we go. Okay. All right. So we'll get started. So one of the things that I'd like to share, and I've been starting to look at a little bit more and include in my presentations and in some of the information that that I share and the data that we collect, is just some of the things that we encounter in everyday life that relate to the prominence, how prominent substance use is within our culture in South Dakota. I was driving to work. Actually, I think I was going to a prevention meeting one morning, and I was taking some back roads, and I was going to a prevention meeting in Sioux Falls, and I came across this sign. And if you can't read the sign, what it is it's an advertisement for a community rummage sale, but the promotion, the signage, and everything is supported by the beer distributor, the Michelob Ultra. So that was just one that I saw. This one was shared with me by courtesy of a police officer from Box Elder, and I don't know if any of you noticed something kind of strange about this sign. I'm sure that this was read many times before it was printed, but nobody seemed to think there was any issue with having the statement in there, food, fun, beer for the whole family. I just thought that I think we've become desensitized to how much alcohol and other substances are involved in our regular daily activities and celebrations, etc. And I'm sure all of you, if you look around your communities or as you go around this summer, will see signs that are something like this. And we don't think anything of it. I don't know how many of you are following the recent, what they call deeming by the federal agency now. E-cigarettes are now deemed to be underneath the they're equivalent to, essentially equivalent to tobacco, and can be regulated by the Food and Drug Administration. Part of that effort and part of what's been happening in regards to tobacco is substantial limitations on signage and advertising and where the products can be placed within stores, etc. We're not at that point in regards to alcohol yet, but I don't know if that will happen. That might be something that will happen. But one of the reasons that they are really looking at placement of advertising in regards to signage for tobacco and now e-cigarettes, etc., is because of the unique targeting towards youth and children of some of the advertisements. And so that may be something that we will see from the prevention standpoint going forward in regards to alcohol. But just something to kind of keep in mind and kind of keep an eye on as we move forward in regards to the prevalence of alcohol within our communities, etc. So one of the things that we try to do with data, and those of you that know me know I like to use this slide, and I think it's a really good illustration of what we're trying to do. Oftentimes, our perceptions are not aligned with reality, and what we're trying to do with data is making sure that our judgments of reality are based on sound facts and that we have a true picture of reality. If we have if we have a misperception of what is really happening within our communities, and we're acting on information that isn't based on solid data, we might be engaging in activities that aren't going to have much of an impact on our issues within our communities. And so that's why I like to really try to have people step back, try to leave their perceptions at the door, and just take an honest look at what is happening within their community and what is the data really telling us. So the way I've set this presentation up is I'm going to just talk a little bit about what some of you might consider a little bit of the mundane, boring side of things, but some of the basics of what epidemiology is and the use of data is all about. And then we'll get into actually talking about some of the statistics and indicators for our state. So one of the challenges is that when we look at data and when we're trying to understand what the issues are within our communities is we have to figure out who is using the substances, what substances they're using, where are they using them, when is also important, and then the why, of course. And so we have to kind of understand all those pieces together. So let me just give you a little bit of an example of the who. You know, the who really could be youth, it could be young adults in that age group of 18 to 25, could be older adults. And then if you look at different products, different substances, that who changes a little bit. The what also changes a little bit depending on what substance you're looking at and the target population. The where is quite interesting because I don't know if any of you use the PRIDE survey within schools. If you're working with school districts and they use the PRIDE survey, there are some questions within the PRIDE survey of where students use alcohol or tobacco, etc. And the patterns of where they use different substances is slightly different. And it's also important to understand when you're thinking about different prevention efforts. The when also shows up too as to when they use. And some of the slides I'll show a little bit later will illustrate that South Dakota is really what I call a binge state. We consume lots of alcohol, but we consume it in a binge factor. And typically in a binge, that when is related to weekends, kind of the holidays, other event types of things. And then, you know, the why piece can get into, you know, is there some underlying mental health, behavioral health issues? Has there been some trauma within the family? Has there been some trauma within the community or some other type of traumatic event? There may also be some comorbid things going on as well. Or there may be peer pressure or some social norms or something along those lines. So what we try to understand is a little bit about the frequency, how often are substances used, and what does it really mean in terms of the use of these substances, what's the impact upon that individual and in their family, their community, their friends, etc. And then we try to look at what are the underlying causes or risk factors that are supporting the use or encouraging the use of substances. And it may be easy access, it may be the prevalence of alcohol around, it may be the prevalence of tobacco around or marijuana or whatever the substance might be. All kinds of different risk factors, maybe social norms, etc. All kinds of things can fall into those categories. And to truly make an impact, we kind of have to understand what are those underlying issues and how can we address them the most effectively. So a couple of key concepts to think about, and I've put this in terminology that you might consider more of a medical model, but that's where epidemiology comes from. And but it has a very close link and tie to the work we do within prevention. And we may be working on prevention of different substances, but we really are looking at healthy lifestyles and healthy individuals, which ties back to and links back to a medical approach as well. So a few things to keep in mind and think about is the pre-pathogenesis, and that's really before the disease is present, or we're able to document or determine that that person has the disease. And in this context, I'm using disease in terms of the term of somebody that's using substances on a regular basis or in an unhealthy manner. Maybe would have an abuse diagnosis, or maybe have a dependence diagnosis. So think of it that way. So a couple of things that we want to look at, and when you're thinking about it, whether you're looking at substance abuse issues, or whether you're looking at cancer, or whether you're looking at diabetes or any other type of disease, one of the things that you're interested in trying to find out from a data and epidemiological perspective is who is susceptible to the disease. There are some conditions, some of them being genetic, and some of them being more social, for which individuals are more susceptible to any type of disease. And you can think of many of them. You know, there's some things where heart disease that runs in families, and biomarkers, et cetera, for other diseases. And in terms of substance abuse, there are some susceptibilities based on individuals' experiences, their environment, et cetera, that make them a little bit more susceptible to using substances and becoming, say, addicted, or using substances in an abusive manner. Then you also have individuals who have the disease, or are using substances in this case, or that may have some type of other disease present, but they've been able to adapt and still function. And you know, I've been working a little bit with recovery groups, and they often will use the term of the functioning alcoholic. Will be a term that people in recovery will use, and that they refer to. There's many individuals that really truly are alcoholics, but they're able to still function within their daily life. So they have adapted to be able to maintain and manage their substance use, at least at this point. And so those are things to take into consideration. What are the adaptation? Then the next piece is pathogenesis, and sometimes you have diseases where there are no symptoms and you can't detect anything. And then you have the issue where you can actually detect the disease. And for instance, with some diseases, you may have symptoms that you can look at very clearly and identify that the disease is there. And then others, and some of you probably are aware of this, you go through many tests trying to figure out, well, what exactly does an individual, maybe a family member, yourself, or somebody that you know, have in terms of what disease, and the medical community is trying to figure it out, running lots of different tests. Well, we have a little bit of that on the substance abuse side too, in terms of how do we detect that there is an unhealthy use of substances, and how do we define that, and how do we accurately detect that within a population. Couple of things that I just always like to throw out there from a data and statistical perspective. So hopefully sometime along in your training you've heard the term that correlation does not equal causation. What we find within the data that we can look at is we can look at very close relationships, correlations, and associations, but we don't always have the data to be able to say that there is a causal relationship between one activity or one data marker and a resulting behavior. We can say that there's a relationship, but we don't have the statistical data to prove that it is a causal relationship. And so oftentimes you'll see correlations and associations within the data. And I always like to caution groups that I talk to like this to make sure that you understand that there's a difference between an association and a correlation and a true causal relationship. And so just one thing to kind of keep in mind. Then there are other statistical approaches and data that we can pull together, and there's been many research studies done related to substance use that can prove direct causal associations and direct causal relationships. And so those things are things to keep in mind, and I like to put those out there because when you're looking at data, and particularly population-based data, most of the time you're looking at data that falls into the first category, where it's associations and correlations. And that is, you can look at, say, income data within your community, and you can look at substance use consumption data. And you can look at associations between income and consumption, but that does not necessarily mean that there's a causal relationship between income and resulting substance use consumption. So that is an example that I like to keep in mind, and I wanted to put that out there just because sometimes individuals that aren't as familiar with data and statistics will indicate that there's a causal relationship between things when in fact it really is truly an association or a correlation and not a causal relationship. Okay. So back to our challenges. So how do we identify those individuals in a population who truly have the disease, and what are those behaviors that we really want to look at? And so I think that's important to keep in mind as to what is that underlying definition that we're truly trying to look at, and how do we define the disease or the behaviors that we're concerned about. So to be able to do that, we need to be able to screen, or we need to be able to collect data within a population in an accurate manner to identify how many individuals have the disease that we're looking at and how many do not have the disease. And that's important information to have from the prevention perspective, and I'm assuming that you've had some discussions or will at some point have some discussions on oftentimes there is a perception within social norms that more people are actually using substances than truly are using alcohol. I'll use alcohol as the example. And in those instances, it can lead to more people thinking it's okay to go ahead and use alcohol, particularly individuals that are underage, because they'll justify it by saying, well, everybody else is, or most of my friends are using it anyway. And it'll make it a little bit easier for them to engage in the behavior. So it's really important to get an understanding of how many people truly are using the substance and how many are not, and quantifying whether it is a problem or is not necessarily a problem yet. To be able to do that in a reliable manner, and I'm using the term reliable twice here, but it's really important so that we know that the data, the information we're basing our judgments on and our programming on really is reflective of reality. And so we need to have instruments that are reliable, and we need to have instruments that are valid. I'm going to spend a little bit of time talking about reliable. Do we have, let me give a couple of examples of reliable, because reliability is a very important concept, but it also can sometimes be misunderstood. So oftentimes what they'll do to measure reliability is they'll do a test-retest type of approach, and they'll see whether or not individual scores are very similar on the first test compared to the second test. And that's one measure of reliability. Another example of reliability is I like to use the analogy of a clock, and I often have to be careful because the traditional clocks with the hands and the arms on the clock aren't as prevalent as they used to be. But if you think of a clock that is has an hour hand and a minute hand, and say it's broken and it's measuring 4 o'clock and it broke at 4 o'clock. That clock always reliably measures the time at 4 o'clock. Okay? So it is reliable, but that clock is not valid And I'll get into valid in a little bit, because that's not the true time. But it's reliably measuring what it thinks the time is, and it's consistent. You can also think about, many of you may have thermostats in your car, and in one of the vehicles that I drive, it always seems like it is consistently a little bit warmer, measures a little bit warmer than it really is outside. So it's very, very reliable in how it measures the temperature, but it's not valid because it measures it a couple of degrees warmer than it truly is. Now I'm going to switch to validity, which is it relates to reliability, but it's not as it's a little bit different. So validity can be thought about as, are we measuring what we're trying to measure? Are we truly measuring what we're trying to measure? And in many of the cases that we're looking at is, are we measuring behavior patterns related to how people consume alcohol appropriately? And is it a true measure of that consumption pattern? And you could talk about validity in terms of sensitivity, and that is the ability of the test or the survey to correctly identify the disease, meaning we're able to identify those individuals that truly do have this disease. Specificity, on the other hand, is the ability of the test to correctly identify those individuals who do not have the disease. And you may be thinking, well, if you're able to do one, aren't you able to do the other? And it often depends upon the question and the individuals. And we all know that we have some individuals within our community that will minimize their substance use or their consumption patterns. If any of you have gone to physicians lately or to a doctor's visit, often they will ask questions along the lines of how many how often or how many drinks do you have a week or something like that. And you have some individuals that will minimize it. Oh, I have a couple a week kind of thing. You'll have some individuals that will be more honest, etc. And then you may also have the experience I've had with the physician says, you don't drink or you don't smoke, do you? And kind of leads you into the answer that they want to hear. And so I think it's important to think about those different things as you're considering and you're looking at data that you may have collected or that you're looking at that comes from your school or your community or some national data, is how was that information collected and what's the reliability of the information in terms of the consistency of how questions were asked and sorry about that. My other phone's ringing here. Just give it a second and it will hang up. Okay. So I think it's very important to understand, how the questions are asked, what questions are asked, and how they might be viewed by the people responding to the questions, and that will give you some indication of how valid and reliable the information is that you're looking at. Okay, so a few things that I just wanted to, that's as far as I'm going to go into some of the, let's say the underlying theoretical and methodological components of evaluation epidemiological work. What I wanted to do now is just talk a little bit about the different data sources that we have available to us at the state level to pull our data together for state indicators. So the first is some of the national data sets that we use. The first is the Behavioral Risk Factor Surveillance System, and that is a system that is overseen by the Centers for Disease Control, and it is collected and put together in conjunction following a very, very substantial protocol with the departments of health within each state. And this survey is a telephone survey that is done on an annual basis. And they survey the population for behavioral risk factors. They have a few substance-related questions, some behavioral health-related questions, lots of health-related questions and disease-related questions within the survey. The challenge is, and I always like to underscore how the information was collected. It is a telephone survey that now includes cell phone numbers. So it's what they call a random digit dial, and they have it set up so it will collect. They'll call numbers across the state that are spread out appropriately and balanced across the state, so they get representation from across the state. The next survey is the National Survey of Drug Use and Health. And that is a survey that is done by the Substance Abuse and Mental Health Services Administration. This is a very large survey. They contract with RTI, which stands for Research Triangle Institute, and they've been doing this survey, boy, it goes back quite a few years. This is an in-person computer-assisted survey, and what they do is they hire surveyors and trained surveyors, and they give them a laptop, and they go through the population and they select out. In South Dakota, they do about 800 surveys, I believe, a year or every 2 years. I can't remember for sure right now. Yeah, they do it every year. I'm sorry. And what they do is, and those individuals that are selected are spread throughout the state and population. This survey is individuals age 12 and up is who they survey. And so the surveyor will meet with the individual. I think they get paid around $50 or $75 to participate in the survey, the individuals that are taking the survey. And so the surveyor will meet with them. They'll set up the computer, and they will help them with the technology, but the computer asks them the questions and they respond, and the computer records the questions. So you don't have the intent is that by having the surveyor there, that surveyor is not influencing the individual's answers. The individual's answers are confidential and not influenced by that person actually asking questions, the surveyor asking the questions and writing them down. And the intent is that you get more honest responses and answers, or that's the hope. So that's the National Survey of Drug Use and Health. Now, I should have mentioned with the Behavioral Risk Factor Surveillance System, there's about 6,000 to 8,000 data points or individuals that respond to that survey every year. With the National Survey of Drug Use and Health, that survey is of about around 800 to 1,000 individuals a year across the whole state of South Dakota. Okay, with our population being around 850,000, that's you have to kind of think about, well, who's going to be responding to these surveys and how accurate are the measures, and that gets back to the validity and reliability of the information. Okay, the Youth Risk Behavior Survey, which you may have heard about a little bit, is a survey that's also done by the Centers for Disease Control. It is focused on youth risk behaviors, all related to driving and riding in a car, using seatbelts, health behaviors, all kinds of different things. This survey is collected every 2 years within high schools across the state. They survey freshmen through seniors. And the survey is, as I said, done every 2 years. What they do is they randomly select schools to participate in the survey, and those schools have to agree to participate. Those schools do not, I've never heard of the schools receiving their own individual data from the survey. It's always aggregated into a state data, but not an individual school data. And the other thing is, in larger schools, not every freshman, sophomore, junior, or senior will actually take the test. They'll select randomly a few classrooms to do the survey in. The actual numbers, and I'm forgetting right now, we'll probably see it a little bit later in terms of the number of respondents that respond to the survey, is, again, it's in a sample, and typically it's in about 25 to 30 schools across the state each year that participate to get the sample. The last data point that is available as of Monday, I checked Monday morning, was through 2013. The 2015 data was collected. There was some problems with the sampling. They didn't have enough respondents, etc. And so they had to go back and do an addendum or a resurvey. And that information, I've talked to the health department, should be finalized, and they should be releasing the 2015 Youth Risk Behavior Survey data sometime in early summer is what I've been told by the health department. And so that should be coming out shortly. And that's, as we get into some of the data, that's a really important data point for us here in South Dakota, and you'll see why once we get into a little bit of the data here in a little bit. Okay. Then the next one is the National Center for Health Statistics. This is also from the Centers for Disease Control, and this collects your birth and death and some of your other morbidity data that's mandatory report information. And that comes from basically your state health systems, your Department of Health have a reporting requirement system for your basic statistics in terms of births and deaths and those types of things. And I'll share a little bit of that information a little bit. But then also there are certain conditions that are coded in terms of that are mandatory reporting types of conditions that have to be reported into the state. So communicable types of diseases are mandatory report diseases. And some of them have a relationship to substance use, and so that's why we look at some of the statistics from there. Then on the crime side, we use the Uniform Crime Report data from the Federal Bureau of Investigations, the FBI data. And that gives an indication of the trends in different crimes within the state. So I have some of the state data listed there. There's Department of Social Services data, which is some of the prevention program data, as well as the treatment data. Public safety, that's where the highway safety data comes from, number of crashes and individuals involved in alcohol-involved crashes or substance-involved crashes. Department of Health data has quite a bit of information. There's a hospital discharge data set that's very useful, and we'll share some of that information. Department of Education, you can pull some of the data on the number of students and the number of students that are receiving free or reduced lunches, and as well as demographics and school performance and those types of things. We use our Unified Judicial System data. They have a very nice annual report that is broken down by counties, and you can look at different conditions, etc., in terms of the crimes and number of individuals that are going through the judicial system. And also our Department of Corrections, and there's data within the population that is incarcerated, and substance abuse is a substantial portion. I don't know if I left it in this set of slides, but I believe about 85% of the individuals that are incarcerated have some type of a substance use diagnosis. And so it's a substantial burden within our correctional population. And there are lots of other data sources that are available. One that I'll mention that I don't have listed here that's a very good indicator, and I'd encourage you to look at it if you're trying to look at some county-related data, is the Helmsley Foundation has, and they have an office in South Dakota, and if you Google them you can find it, but they did a behavioral health survey about a year ago, and there's quite a bit of data and information related to behavioral health conditions within South Dakota, and particularly within counties and populations. Challenge is some of it's not broken down to some of the, it's all adults. It doesn't have any youth included within that particular survey. Okay. So one of the things I like to start out with is just kind of a little bit of the populations and demographics information for our state. And this is kind of a nice handy chart that shows an estimation of the number of individuals, excuse me, estimated to between ages, by their age and gender, for the total population and for the white population and the American Indian population. And one of the things that I like to point out, and if you do the percentages on these, our Native American population is percentage-wise is a much younger population than our overall population in the state, particularly the white population. It's kind of difficult for us to look at, although it's starting to grow more and more, some of the other ethnic and racial groups in the state. The numbers just aren't as large, and they're kind of pocketed in different areas within the state. And but as a whole, they make up 1 or 2% of the state, and it's pretty difficult to look at those percentages and trends within lieu of everything else. But if you're living in Sioux Falls or Minnehaha County, and you look at the demographics there, it's quite a stark contrast to our state population demographics. Or if you're living in Rapid City, the same type of thing. Or if you're living on or near one of the reservations, and so I always encourage individuals to, okay, you have the state population as a whole, but be sure and try to look at your own community or your own county demographics to make sure that you have an understanding of the composition of your own population and percentage-wise. This chart here lists the 5 behavioral health regions, and every single dot represents approximately 100 individuals. That doesn't mean that 100 individuals is right there living where that dot is. Those dots are randomly distributed within zip code areas. Okay, and so within that area around those dots is where 100 individuals live. I like to show this because it helps illustrate the challenges we have with vast spaces and very few low levels of population across the state. But then in certain areas, it's fairly populated. You can see where all the communities, the larger communities, are very easily, and how the populations are centered around that. And that also is important to think about and take into consideration when you're thinking as a state of how do you do prevention programming across the whole state. Okay, now a few general health statistics and indicators, and I like to show this because it really underscores the point that substance use issues are an important component within many of our health indicators in the state. And so this, and I did not update it. I know the health department has updated information on there, but it's fairly similar. We have our live births and our deaths and our neonatal deaths, etc. And so these are just some of your general vital statistics that the health department has and keeps and publishes on a regular basis. This is the number of live births summary, and it summarizes the number of live births. And what I like to point out here is the rate difference between white births and American Indian births. And so essentially the white births are 12.6 per thousand, where the Native American births are 26 per thousand. And so over double the number of births for our American Indian, Native American populations per thousand population compared to white births. And that kind of illustrates that it's a much younger population than our white population. Okay, so these are just some basic facts in terms of each day in South Dakota there were an average of 33.5 live births and births to teenagers, etc. And if you look at it, I've kind of gone through this, and I've seen research studies, all of them that have little triangles on them, that link substance use related to each of these health conditions or health statistics or indicators. And it's pretty substantial. You'll notice I think the only one I don't have marked on there is marriages, and I've often been called out that, well, that can be related to it as well. So, seriously, in all of the, if you think about it, there are situations in which substance use can impact each of these health indicators. So if we look at the 10 leading causes of death, and this is from the 2013 numbers for the state, Heart disease was our leading cause, followed by cancer, then accidents, etc. But if you look at the top 10 leading causes of death, there is substantial, and people could argue that some of the others, but 5 of them are very closely related to substance use related issues. There may even be some links to Alzheimer's that I've seen, and there certainly are some links to diabetes as well, but I didn't mark that on here. And there certainly are some links to chronic liver disease and cirrhosis as well, and I didn't mark that one. But there are substantial relationships between substance use and the 10 leading causes of death in the state of South Dakota. These next charts, and all of you have them, they break the same conditions down. Now this is the top conditions or hospitalizations by age for individuals, and this comes from the hospital discharge data set. So essentially it's what are the conditions that individuals were hospitalized by age. And if you look at these, and I have I've kind of marked where injury and poisoning comes in and some of the other conditions that are, and what I've marked is the behavioral health related conditions, directly related conditions to behavioral health. And I use behavioral health as a general term to include all mental health related issues as well as substance use related issues. Some may argue that there could be some relationship to some of the other diseases that are marked there, and what I tried to do is just pick out the major ones at this point. But if you look at it by population, age group, and the reason why individuals were hospitalized, for our younger ages, it's one of the top reasons why individuals were in the hospital, behavioral health issues. So, and this data set is available, and there's a very nice report on the Department of Health's webpage that has this information in it. There is also out on the Department of Health webpage a searchable database that will allow you to look at individual hospitals and how many individuals and the cost of certain diseases for individuals that were hospitalized by, and you can look at it, say, by, let's say, Queen of Peace Hospital in Mitchell. So very, very interesting. Just looking at, and then they also have it by level of severity of the individual. They have a 1 being very low and a 4 being very high. And some other work I was doing with another group, we were looking at some of the data. And for individuals in one disease category, when you go from a 3 to a 4 in level of severity, it doubles the cost of from about $30,000 of a stay, and this is for, I believe it was pulmonary diseases, to about $60,000 for a stay from level of severity. And the whole issue is if we can get people identified and treated earlier, and so that they don't ever move from a 3 to a 4 in terms of severity, you can save a ton of money very quickly. You can save half the costs very quickly for individuals. And I think that's something that we need to take into consideration in prevention is how do we identify those individuals and how do we implement the prevention activities that prevents folks from engaging in adverse health behaviors that create substance-related conditions later on. And what are the savings that we can do from those prevention efforts, and how do we get really good at preventing people from moving down the continuum to higher levels of need in terms of health conditions. Okay, so now I wanted to just go over a little bit in terms of alcohol use. I'm going to get some coffee before I go into this. So the first chart I'd like to show and talk about a little bit comes from the Youth Risk Behavior Survey. This survey is the one that I was talking about that comes from the Centers for Disease Control. It's administered by our Department of Health, and it provides an estimate of the number of youth that have used alcohol in the last 30 days. And you can see the trend going back to 1991. And South Dakota was either at or above the national average in terms of reported 30-day use of alcohol by our youth through about 2007 is when we were right on, very close to the national average, fell below it slightly, and we're right on the national average for 2011, and then fell below it by 2013 by about 4 percentage points. One of the things I like to point out here is that in about, I'll just say around back here around the 2000s or so, 1999, 2000, sometime in there was a concentrated effort to really enhance our prevention activities in the state. And you see a very nice correlation to that. And notice I use the term correlation, not causation, in terms of a downward trend in our state estimate of number of youth reporting using alcohol in the last 30 days from that time point on. So essentially from about 2000 through 2013, in about a 13, 14-year period, we dropped the rate from around 59% down to about 30%, so 30.8%. So quite a substantial reduction in our students reporting 30-day use of alcohol over that time period. And I would venture to say that this is a direct relationship to a substantial amount of effort put in on the prevention side and continually looking at the issues of underage alcohol use, messaging, programming, and also environmental controls that have been put in place over that time period. And the result is, a substantial reduction, almost a 30 percentage point reduction in reported substance use by our youth in the past 30 days. This chart just is more for your reference, but I like to show this. We know that as youth age, that the number of youth engaged in risky behaviors increases as youth age. And so it's important to have an idea of about 23% of our freshmen report using alcohol in the last 30 days, while our seniors, almost 44% report using alcohol in the last 30 days. And so you can see a pretty good jump. You have a little bit of jump from freshman to sophomore, a little bit bigger jump from sophomore to juniors, and then a pretty substantial jump from our juniors up to our seniors. And I think we all know, just in knowing our youth and knowing what is going through and how those youth are developing and aging, we all kind of know that that's a natural progression, and we have a percentage of individuals that will each year will begin to engage in those behaviors. And I think from a prevention standpoint, we have to target where those youth at in their development, their emotional and physical development, and how do we best match our programming to where they're at to help them make better decisions. And even if we can keep a handful of youth within each community from not engaging and delaying their use of alcohol, it's a substantial win, because we know the younger individuals engage in alcohol, the younger they start to use, the more likely they are to have alcohol-related problems later on. So the more we can delay that age of onset, the better off we're going to be down the road population-wise. This just shows the same information over time to show that our rates decrease by freshmen and by seniors compared to the U.S., and that it's just not within one group where we saw all the declines. And so the other thing I'd like to show here is this is the trends in binge drinking, and we're going to get into a little more binge drinking, as reported by the National Survey on Drug Use and Health. And you'll notice, according to that survey, that only about 7% of our 12 to 17-year-olds are reporting binge alcohol use in the past month. And that's why I always try to I try to make sure that everybody is aware of how the different surveys are collected and the source of the data that's being presented. In contrast, when you look at the data from the Youth Risk Behavior Survey for our freshmen through seniors, you see a rate, and granted the person that's a freshman, we're not including 12-year-olds in this particular age group, but this comes from the Youth Risk Behavior Survey. When we look at our freshmen through seniors, the reported binge alcohol use in the past month was around 17% for South Dakota. I'd also like to point out on this trend chart here is that, again, about 1999, 2000 is when we started to see the reductions occur overall, and again, that correlates very highly to when substantial targeted efforts were implemented within the state of South Dakota. You can see there was a substantial gap between our rates of binge drinking over time compared to the U.S. rates until about 2009 is when the gap really closed. We saw a narrowing of it over time, but it really closed to being fairly close to the national rate about 2009. And that kind of comes back to one of the statements I made earlier, that South Dakota is truly at least from my view of the data, is truly a binge state. We drink alcohol in a binge manner, and that's what this is showing. If you remember from our 30-day use chart as well as for this chart, in 2013 we're below the national average by a couple of percentage points, which is a substantial reduction. Again, almost a 30 percentage point reduction from where we started in our high nearly 15, 16 years ago. But this is the last data we have for the Youth Risk Behavior Survey is 2013. And as I said, we are waiting for the 2015 data. And that data should be coming out again, hopefully very soon here, hopefully in June. And that data, that next data point in 2015 is extremely critical to look at. Since we first fell below the national average in 13, the real question is where are we going to be in 2015? And so that's something that we need to look at, and I'm anxiously awaiting to see where that's going to come out. And it's very critical because that's going to help identify whether or not we have a rising trend or if we need to continue to maintain the activities and the advances we've been able to make. So something to keep your eye on. The next few charts, again, are the similar charts just to kind of show the comparison by age groups or by grades. This chart is includes white and Native American. In South Dakota, the X's are where we actually have some data points that are valid data points of Native American individuals that were included in the Youth Risk Behavior Survey. We did not have, every year we don't have enough Native American participants in that survey to be able to have a valid data point to be able to pull out the data by Native Americans. So we have some limitations with their data, but you can see where we do have valid data points, particularly 2007 and 2011. The Native American rates are higher than that for their white counterparts. So here's just a comparison of the binge drinking by age group, by each of the different grades, and you see the same trend as individuals get older, more of them are engaging in the risk behavior. So we just, something to keep in mind, and again, if we can keep individuals from delaying their engagement in that behavior another year or two, the better outcomes we'll see down the road. excuse me, this comes from the National Survey on Drug Use and Health, and here we're starting to switch age groups a little bit. And again, I'm going to remind you, the National Survey on Drug Use and Health, they survey individuals age 12 and above, and this is kind of an estimate of the whole population. When we look at binge drinking in our whole population, the last line there is where I have the rankings based on comparison nationally. And from 2007 through 2012, we were either the third, second, or fourth worst. In 2013, compared to other states, we were the sixth worst in terms of having the sixth highest rate per state in the nation. And so that's one of the, we've always been in the binge indicators, we've always been in one of the top categories in the nation. This just illustrates that same information by age group, and the National Survey of Drug Use and Health only breaks the information out by the age groups of 12 to 17, 18 to 25, and 26 and above. You can see in our 18 to 25-year-old groupings, our estimate for South Dakota is substantially higher than their national peers when you compare it. So their national peers are about 38%, while we're about 46% for South Dakota, with individuals in the age group of 18 to 25 reporting binge drinking. And then in our 26 and above population, we're at about 26% report binge drinking in the past month, compared to about 22-23% nationally. And so most of our binge drinking is happening within our 18 to 25-year-olds overall, and it does happen in our older population as well, but it's a substantially larger in our 18 to 25-year-old groupings. Which leads me to trends in our alcohol consumption patterns. And this actually I have through 2012. I didn't change the title. It is through 2013 data. This chart shows the average amount of absolute volume of ethanol or alcohol consumed per capita. And what that means is, all of you know that there's like, if you look on a beer can or on wine or some other spirits, it indicates the percentage of alcohol that drink contains. Typically, most beers are around, typical beers are around 4%. And so what that means is, and for South Dakota, we're at about 3.2 gallons of ethanol per individual over the age of 21 annually in 2013. That translates to about 660 plus 12-ounce cans of beer that are at 4% alcohol. And if you do the math on that, that's at least a 12-pack a week. And that is per everyone over the age of 21. Now, if you look at some of the statistics, and it shows that, you know, about 60% of individuals over the age of 21 had some form of alcohol in the last month. That leaves about 40% of the individuals that have not had any alcohol in the last month or did not report drinking last month. So then if you would take 40% of the individuals out of the population and you redo this calculation, and you have to do some estimates and guessing, but you're somewhere around 4 to 5 gallons of absolute ethanol per individuals that are drinking individuals, and drinking being defined as somebody that has used alcohol in the last 30 days. And so you start to get to some pretty high volumes of consumption of ethanol annually for those individuals that drink within our state. I have some comparisons there. The national rate is at about 2.6 gallons, so we are not quite a full gallon above the national average. Although our neighbors to the north, in North Dakota, and to the northwest in Montana, are over a gallon higher than the national average. And And then Minnesota and Wyoming are a little bit below us, and Iowa and Nebraska are right at the national average. You know, and one of the things to take into consideration is, you know, what's really different between us and Nebraska or us and Iowa, or even Minnesota or Wyoming. And then what's different about North Dakota and Montana that has them higher than where we're at. The interesting thing about North Dakota, and many of you have heard of the oil expansions in North Dakota, and you can see a huge jump in around 2010 and 11, and that's when the Bakken Reservoir began to really expand. There's quite a correlation in terms of the volume of ethanol consumed per population and when the Bakken started. The last data point, or 2013, it did dip a little bit. I'm anxious to see what 14's like, and then 15 when they come out with those numbers, to see whether we can see the rates change as oil prices have changed and the level of activity in the Bakken Reservoir has changed over time. It'd be a very interesting comparison. But you do see those types of things happening with specific instances happening within states. And North Dakota is a very prime example of that in terms of looking at the correlation between when the Bakken started and this absolute volume of ethanol. Okay, the next section here is we're going to talk a little bit about the arrest and DUI data. Excuse me, I had to get a little bit of coffee to keep my voice lubricated. So the top line is showing the proportion of all fatal crashes that were alcohol involved, fatal crashes. And what I'd like to point out is that of all of our fatal crashes, and it's dropped down to about somewhere around 30%, and it bounces around because we don't have a lot of crashes every year that are fatal crashes. But about 30 to 35% of all fatal crashes are alcohol involved. And that's been the trend for about the last 4 or 5 years, somewhere in there. Okay, and that is going to bounce around again because we do have we don't have a large volume of crashes. One single crash that has 4 individuals in it that is alcohol involved will really change these numbers substantially. And so you can see how that will bounce around. But then if you look at the proportion of all crashes that were alcohol involved, this is not fatal crashes. These are just general crashes where somebody wasn't killed. Only about 8% of those were alcohol involved. And so the moral of the story is that if you are involved in an alcohol-involved crash, you have a much higher chance of being killed compared to being in a crash that was non-alcohol involved. And I think we all know that. Typically when your alcohol-involved crashes involve people that forget to wear a seatbelt, then you have the impairment issues of not knowing where they're driving or driving on the wrong side of the road and those types of things. Then typically you also have high rates of speed involved. And so that is something to keep in mind, and how do you prevent alcohol-involved related crashes. So when we look at our DUI filings, and I'm going to underscore the term filings, this is from the South Dakota Unified Judicial System. And a filing is when there has been an arrest for a DUI offense and the paperwork has been filed with the court. And I say that, and I'm saying that very precisely and very carefully, for the reason is there are times where there is a DUI arrest and something happens and that arrest does not lead to a criminal filing or a filing within the court system. Typically that doesn't happen as much anymore, but it does still happen once in a while, and so that's why I'm using the term filings, because that's how they are listed in the Unified Judicial System report. Blue bars are those individuals that were arrested for a DUI 1, and the red bars are DUI 2s, the greens are DUI 3s, the block at the bottom are combinations of 4s and above, mostly 4s and 5s. And then the triangle is anybody that had its account summation of all the DUI 2s, 3s, 4s, and up for multiple offenses. And you can see we've done pretty good in terms of our decrease in number of DUI first filings over time. Our DUI multiple offenses has stayed pretty steady over the time period. It's gone down a little bit in about 2010, but then it's crept back up a little. And the issue is, and when you look at statistics, and it holds true for South Dakota, is that about 33%, about 1/3 of all DUI first offenders will have a second or a multiple offense sometime within after their first offense, typically within about 10 years. And so from the lowest, our lowest DUI first numbers, which is in 2011, we still have people that are out there in our driving population that have their DUI, that had a DUI first, say back from 2000 on through 2011, that are still out there, that are still having their seconds, etc., that haven't had a true evidence-based intervention program or participated in one of those. And so I think that that's one of the reasons that we're not seeing the reductions in our multiple offenses yet, is we have individuals in our driving population that haven't gone through evidence-based programming. And the reason I say that is South Dakota started implementing an evidence-based program in about 2003 or 4 for DUI first offenders. In about 2005 and 6 is when the 24/7 program started. There was some other programming that started also about that time. And so we really need to look at the trends over the next few years to see whether we're starting to have a long-term impact from those programs. Each of those programs have received substantial acknowledgement in terms of being evidence-based programs, and the 24/7 program is being looked at as a model monitoring program across the nation. And there was some research done on that program from the RAND Corporation that was recently published in The Lancet, the British medical journal, The Lancet, that linked implementation of 24/7 programs in some counties had a reduction in deaths, substantial reduction in deaths of about 5 to 8% related to all kinds of deaths related to, and if you remember from our leading causes of death in the state, I think cardiovascular was on there and a few other of those diseases that have a link to substance use. It showed, their statistics showed a reduction in deaths related to all causes of death within counties, and they ruled out any other reasons for those reductions and attributed the reductions to implementation of a 24/7 program. Well, I think that science is still in its infancy phase. I think it's something that we need to keep in mind and keep an eye on as we look forward to what's the most effective way to deal with our high-risk drinking population that could be drivers or could be within our communities, and how do we monitor those individuals within our communities in the most effective manner. The next few slides just provide you some additional data related to DUI filings and level by ages and by populations, etc. I just provide this information to you as reference and additional information to look at, because I know some of you have an interest in it. One of the things I wanted to point out, and if you remember in our binge discussion data earlier on the binge drinking, that 18 to 25 year age group was very high. And if you look at alcohol-involved fatal crashes and percentages, that 19, and I don't have 18 highlighted, but if I would have highlighted 18, you'd see that that group makes up about 18 to 25, makes up about 21% of all fatal crashes. But if you look at the actual number of individuals in our population, it's a much, it's not as many as in the rest of the population. So they make up a substantial portion. And then the age group slightly above that, that 25 to 34 age group, you're looking at 24% of the population of alcohol-involved fatal crashes, and then 35 to 44. So it's really that that younger group, and then that 25 to 34 age group is a substantial contributor to our alcohol-involved fatal crashes. These are fatal crashes and alcohol-related arrests by time of day, and it's interesting to kind of look at when the time of day occurred and the percentage of fatal crashes. So it's just to kind of keep in mind that there are certain time periods where it's a little more risky to be on the road, and the risks are higher for alcohol-involved crashes. This just looked at number of driver's licenses, and one of the things that happens is if you do have a DUI, there's certain restrictions that are placed upon your licenses, and just to see. And one of the challenges is that some of our multiple offenders, even though they don't have a license or a valid work permit or something, they end up driving anyway. So how do we manage that in the most appropriate manner to prevent crashes or to prevent drunk driving down the road? Okay, as I mentioned, in our correction system, we see a substantial portion of individuals that either have a diagnosis or a dependence related to substance use. If we look at our arrests, all of our arrests, and this is only arrests that have a direct relationship to alcohol, such as minors in possession, open container, DUIs, those types of things. It's not looking at burglaries that may have a where the individuals may have been drunk, or maybe burglarizing to sell the whatever they could steal to buy methamphetamine or marijuana or whatever it might be. If we look at it, this is alcohol-related arrests. There's about 35% of our arrests are directly related to alcohol within the state. And nationally, it's just a little over 20%. So much higher. And again, it comes back to we're a bench state. And the reason I say that is when you have that high BAC concentration, that's typically when you start to see behaviors that get individuals into trouble, and particularly criminal justice related involvement. And so it's a substantial challenge for us here in the state. We have been either the highest or second highest rate related to alcohol-related offenses over time since, and I've been tracking it since around 2002, 2003. Excuse me. And so it's just another indicator to keep an eye on as we look at these issues going forward. If you talk to your county sheriffs and your police departments, I'm sure they will substantiate that these kinds of issues and be able to provide some real detail and maybe some pretty good stories related to how much of their efforts are related to substance-related activity. Okay, just want to spend a little bit of time on tobacco. I know I've spent most of my time, and most of the things I've shared is related to alcohol. So just a little bit on tobacco. This is from our Youth Risk Behavior Survey, and kind of looks at a number of the indicators. The nice thing in all of these indicators is there's been a substantial decrease over time. And particularly ever smoked or current use of tobacco, we've seen substantial reductions, as well as the percentage of individuals that ever smoked before the age of 13. Substantial reductions. And this is from the National Survey on Drug Use and Health, and it shows a similar type of trend over time. And this is also from the National Survey, and this is the perception of harm, and you can see that we have had a little bit of impact on the perception of harm of smoking, though we still have a ways to go. This comes from the South Dakota Youth Tobacco Survey. This is a different survey that our health department does, and this is looking at middle school kids and their current use of tobacco. And according to the 2013 report, 9% of 8th graders were current users of tobacco products as reported by themselves. one of the things I do not have any data yet related to vapor products or e-cigarettes. What I have been hearing is that you're starting to see individuals using these e-cigarettes and vapor products and then switching to traditional tobacco products. And that's something we're going to have to keep an eye on. There isn't substantiated data or surveys out there right now that allow us to look at the use of e-cigarettes within this population to get an estimate. There's a few surveys that are starting to provide some indicators, but we don't have enough at this point. On a side note, we are engaged in a pilot program right now. In fact, I have youth leaving that are out on the road. We are doing the first round of e-cigarette inspections where we're sending youth in to try to attempt to purchase e-cigarettes from grocery stores, convenience stores, and so far in the one county we've done, out of 35 inspections, I think we had 1 or 2 buys, so that was pretty good. We're going to be working in another county over the next couple of days, and we will see what the rates are within that particular county. And one of the other things that we do for the state requirements, it's their SINAR requirements, is youth tobacco inspections. And we inspect 500, we send youth into over 500 survey or outlets annually with an inspector, 16-year-olds, to try to attempt to purchase cigarettes. Our violation rate last year, retailer violation rate, was, I believe it was about 4.5%, which came from a high of over 50% about 15 years ago when they first started these. So we've been pretty good over the last few years at around under 10% violation rates. It fluctuates a little bit if you happen to have a youth, and we take 16-year-olds. We do not take anybody that's 17 or almost 18. We don't take anybody younger, and so we take a range of 16-year-olds, and it depends on the physical appearance and level of confidence of that 16-year-old. You know, some will have higher rates and some will have lower rates of individuals that sell to them. But we try to get a good representation of 16-year-olds. We try not to pick 16-year-olds that look older, and we try not to pick 16-year-olds that look younger. We just try to take the run-of-the-mill 16-year-old. And so we've seen pretty good luck with that. I think the trick is to make sure that we continually have a presence in terms of making sure retailers know that that it is still illegal to sell cigarettes and cigarette products to individuals under the age of 16, or I'm sorry, under the age of 18. And so that's the challenge is there's so much turnover within that employment category of clerks that work at convenience stores and work at grocery stores, etc., that it's a real challenge over time to try to make sure that institutional knowledge is there and that experience is there, and it's a real training burden. So we try to make sure that information is put out there on a regular basis. As we learn more about the e-cigarette pieces, more information will be coming out about that. We'll be trying to share that so that it can be used within the prevention network. Okay, marijuana. So a little bit about marijuana. These are the trends in marijuana use by our South Dakota youth, our white South Dakota youth, and our Native American South Dakota youth, and the U.S. average over time. And the we do have a little bit of a lower rate than the national average. Again, in 2013 is our last data point, and the the South Dakota rate was around 18% of South Dakotan youth reporting that they had used marijuana 1 or more times in the past 30 days. We do not have an estimate in 2013 for our Native American youth, but in 2011, where we did have enough data for an estimate, it was about 48% of Native American youth reported having used marijuana in the last 30 days. When we look at the the trend over time, and I'm trying to see if I have this is the trends in current marijuana use as reported by a National Survey of Drug Use and Health. And again, this one's lower, and this is the 12 to 17-year-olds, so it's a slightly different age group that's included within that. This breaks the information out on marijuana by age groups, 12 to 17, compares it to the South Dakota average, and then breaks it into each of the Department of Social Services prevention programs regions across the state. And if you're unfamiliar with the Department of Social Services regions, Region 1 is kind of the Pennington County and north all the way up to Harding County, down south to Oglala, Lakota, Fall River and Oglala, Lakota County. Region 2 is kind of the middle of the state up to the west of the Missouri River. And Region 3 and 4, I always get confused as to where that's at. One's in the northeast and one's in the southeast. And Region 5 is Minnehaha County, Lincoln County, McCook County, and Turner County on the eastern side of the state, kind of the metropolitan area around Sioux Falls, and then kind of branching out a couple of counties wider. So one of the things that I like to point out here is that Region 1 and Region 2, which is really the western part of the state, is where we see the highest percentage of individuals using marijuana compared to the rest of the state, which, that's where we have some of our largest Native American population concentrations in the reservation areas of Rosebud and Pine Ridge, as well as the Rapid City area, and even up to north of Pierre, the couple of reservations that are up there as well, with Cheyenne River being one of them. So you have all the different issues to look at and to consider in regards to marijuana. I was trying to see if I had the perception of harm, and I do not have the perception of harm in here. One of the things that we've seen with perception of harm over time is that students' perception of harm from marijuana use has decreased substantially, and it is highly correlated with the number of states that have either legalized marijuana for recreational use or has passed a bill allowing medical marijuana, and the advertisement that goes along with those campaigns or ballot campaigns to go through that process. And what we're seeing is, even if it's not in our state where it's happening or where it's been legalized, all the efforts are contributing to reducing the perception of harm of marijuana use. And so that becomes a very important thing to consider in terms of how do you engage in prevention activities and making sure that youth are getting the right information about the potential risks of marijuana, and how do you put that into a programming or prevention information that you're able to share with the youth that you're working with, if you're targeting youth within your prevention activities. We've heard a lot about prescription drugs lately, and I just have a little bit on prescription drugs. There's not a lot of data related to it in terms of indicators that we can pull out. The Youth Risk Behavior Survey does have information on there specific to use of OxyContin, Percocet, or Vicodin, codeine, and etc. And this was the 12.8% ever took prescription drugs without, report ever taking prescription drugs without a doctor's prescription. And so it is something to keep an eye on, and I think we're going to be seeing more and more of this as time goes on. So just one of those other issues. It's never dull within the prevention area. There's always something new to keep your eye on. We've had e-cigarettes. We've had synthetic marijuana. We're starting to see prescription drug use and abuse. And I also want to remind you that this is prescription drugs. It does not ask specifically about other over-the-counter drugs such as Robitussin or some of the other cough medicines, etc. So something else to just keep our eye on and see what happens with this over time. we're starting to see some substantial issues nationally, particularly in some of the states where there's been high uses of prescription drugs and abuse of prescription drugs, and then you see a following spike in heroin use since they're having trouble getting to their opiates and that they were getting through prescription drugs, and then they're converting and beginning to use heroin. So, which brings on a whole other issue, because typically people use heroin intravenously, and then you have some of the other diseases and issues that go along with intravenous drug use showing up. Okay, whoops, I'm going the wrong way. There we are. Other drugs, we've started to hear a little bit more about methamphetamine, and we don't have a lot of information related to population-based use of methamphetamine. One of the things we can look at is within our treatment system, what are we seeing in terms of meth admissions? And this is the trend of South Dakota meth admissions over time compared to the national average. The first chart, and it's using it per 100,000 population. And we are seeing a bit of an increase. The data in the first chart only goes through 2011. Actually, both of these do. So I have seen the later charts, and the trend is continuing, but not substantially. We had a huge spike back in 03, 04, 05, and when we were able to kind of contain it, there are lots of, those of you that were around probably remember all the prevention activities, and we were able to kind of damp it down a little bit, but now it's starting to come back and starting to spike a little bit. We're starting to see some issues within our arrests and within our criminal justice system related to methamphetamine seizures, as well as methamphetamine usage and individuals that are high in methamphetamine committing crimes, etc. Then typically we'll start to see it in our admissions, and we'll start to see it in our prevention data coming along as well. Okay. Want to spend a little bit of time on some suicide-related data. I'm going to just check our time. It's at 11 o'clock. We doing okay, Dodie? I'm assuming that.
We're just doing just great. Sorry, I had to unmute myself.
I figured. I wanted to make sure, because we go to 11:30, right?
Yep.
All right. I'm gonna try to wrap up here in the next few minutes. We'll talk about some suicide-related data, and then we will leave some time for some questions, discussion, if some people have some, and hopefully my voice will hold out that long. Excuse me. So crude death rates due to self-harm, suicide. This is the trend. The blue line is the South Dakota trend, and this data goes through 2013 compared to the national trend. So, and this is per 100,000 population. So we're at about 16, 17 individuals per 100,000 compared with the U.S. rate of around 12 individuals per 100,000. So a bit higher. You can see the comparison to our neighboring states, and that South Dakota has continually been higher than those. Now this is the whole population. When we break the information out, and this last year, thank you to the Department of Health, we were able to have this data extracted from the outpatient data collection system for us. This is what we saw within the Department of Health's data by Department of Social Services regions 1 through 5. And we were able to break it out by the age groups. So the first grouping, you can look at attempts, and there was a rate of 330 attempts per 100,000 for Region 5, which is a substantial number of attempts, just astounding. And that's the first time we've been able to see attempt data. And these are the attempts that ended up within an emergency room or within a hospital system to be counted. You can see the actual numbers there of attempts, and again, this covers a 4-year period of of 2009 through 2013. Then you can also look at the deaths and the regions as well, and the deaths per 100,000. And so it is, and you can see where we're having our spikes. Region 2 in terms of the number of deaths, and that's that region just to the west of the Missouri River, probably out to just past Kadoka and straight south and north from there, gives you a pretty good idea of that region. There were a substantial number of deaths that occurred within there at 60.4 per 100,000. And we've all heard recently of some of the elevated numbers of suicide within our Native American populations. And so this is kind of a precursor to that. Again, I call your attention to this was 2009 through 2013. I know that there's been some additional deaths related to suicide in the last few years in 14 and 15 and even this year in 16. And there are a substantial number of efforts going on to target and do suicide prevention within those communities at this time. So we're able to look at it, and there certainly is a high level of risk within communities. L&E means that there is low number of events, and so that number is too small to actually report or work with, so that you'll see that once in a while in some of the data charts. So over time, this is the total number of attempts by year, and the total number of suicides by year. So in 2013, we had 152 suicides reported in the state, and there were 101,073 attempts reported in the state. And those, again, those attempts were attempts that occurred within a hospital setting or somehow ended up in the hospital so that they would be counted. Granted, there are probably a lot more attempts that did not end up in a hospital or were in some other setting. And the other thing about this is from SADAHO. That's the South Dakota Association of Healthcare Organizations. So it does not include VA facilities, medical facilities that would be associated with military bases, and it does not include Indian Health Service data. And so, yeah, again, that comes back to the reliability and validity and source of the data, understanding it. I think the data is fairly reliable and valid, but it's only those individuals that ended up in healthcare facilities that would be our hospitals, such as Sanford or Avera system, or some of the other hospitals across and located within our communities, or regional hospital out in Rapid City and its affiliates. And this just provides the same number of information, but also breaks it apart by American Indian, Native American, and in our white population as well. So you see the higher risk for our Native Americans, etc. And this shows the number of attempts and suicides by gender, with our females having substantially more attempts per 100,000, but actual less completed suicides compared to our males. You see the substantial difference. I believe the next chart will provide, yep, this is the one. So one thing that, as I've started to work with suicide data, and I always find that this is very helpful when talking with audiences, is to look at the method that is selected by the individuals who's attempting to commit suicide. The solid red bars on the bottom are poisoning attempts, whether it be pills or some other form. So 40% of completed suicides for females was related to poisoning as the method. And if you look at female attempts, 85%, nearly 85%, were attempts at suicide with the method being poisoning. Now, if you look at our males, of completed suicides, only 11% of them were poisoning, with almost 76% of the male attempts being related to poisoning. Now, if you look at firearms, 22% of females committed suicide with firearms, compared to 52% of individuals committing suicide that were males with firearms. Very few firearm attempts resulted in, as attempted suicides the method was firearms, because firearms is a much more lethal method. And then you see hanging and then cutting and then other methods as well. But basically, our males prefer to use a much more lethal means or method than our females. Females prefer to use poisoning and so on. And so you see a little bit of the differences and probably explain some of the differences that we're seeing. This information becomes very important when you're thinking about means restrictions for individuals that are at risk for suicides. Is then how do you look at the environment and restrict access to firearms, restrict access to substances they could use to poison themselves with, or restrict access to materials they could use for hanging or cutting or other types of suicide attempts. I have some graphs and charts in here, state maps and stuff that just come from the health department, and kind of looks at the rates of substance or suicide across the state. And so those are just there for your reference and may be helpful for you if you're working on some suicide-related activities. So this kind of goes back to that some of the vital statistics data from our state. And if we look at the leading causes of death, excuse me, for all races, and then by white and American Indian. So across all age groups, in all races, intentional self-harm, suicide, was ranked 9th as a leading cause of death for residents in South Dakota in 2013. If we look at it for our white population, it was 9th as well. And for our American Indian population, it was tied for 6th. Then if we look at suicide as the leading cause of death by age groups, for our 1 to 24-year-olds, it was the second leading cause of death. The only reason greater was accidents, and the same for our 25 to 34-year-olds. So if you look at those two top causes of death, with the second being suicide and the first being accidents, that is really substantial. And some may say, well, those accidents were also, some of them may have been suicide as well, and it could be. Those are just substantial areas in which suicide is tremendously impacting our younger population. And then if we look at the 35 to 44-year-olds, it is the third leading cause of death in our state. And then by 45 to 54, it drops to the fifth leading cause of death in the state. And then it drops off the top 5 leading causes of death as individuals get older. One of the unique measures, I like the acronym, the YPL, it's Years of Potential Life Lost. This is a means of measuring the burden of disease on a population. And essentially what it is it's looking at, okay, if somebody died at age 16 and the median expected age, and this time they're using age 75 in this calculation, you look at the amount of years that was lost to a disease by taking age 75 minus the number of years that person was when they died, and you look at the total burden of those years lost by each disease. And you can see that suicide is only eclipsed by accidents, cancer, and heart disease in our state for diseases, leading causes of diseases in the state. Here's some data related to suicide from our Youth Risk Behavior Survey. This comes directly from our youth in terms of that survey. and so felt this is trends and felt sad or hopeless over time period, and you can see where those trends are at. The thing that scares me a little bit about these is that that trend seems to be creeping up a little bit to about 30%. I'm sorry, the South Dakota total was at 22%. And so it'll be interesting to see where that's going to be in our 2015 data set. The question was not asked in 2009 and 2011. And so we'll be able to see what happens in 2015. Ever felt sad or hopeless? Here it is by age groups. It's interesting for me is that you see a little bit of uptick in that 9th and 10th grade, and then it decreases a little bit in our juniors, and then starts to creep back up by our seniors. Kind of that transition point, I think, the way our school systems are set up, contributes to some of this. Okay, trends in seriously considered attempting suicide, and the South Dakota average is about 16%. And so we do see a little bit of a decrease in that. I like to show this because oftentimes when you get some of the survey data back from schools and you have some administrators looking at saying 16% or 18% of our students are saying they've seriously considered suicide. Oh, that's horrible. Part of it is I like to put the reference up there with the national average, and that is fairly common and fairly normal for youth to think about it or explain that they were seriously attempting suicide. That doesn't mean that there isn't an issue that needs to be addressed. It just means that that is something that does occur within that population. But if you start to see a rate that's at 20% or above or 30% or above, then you have a real population issue that I think is indicative of something quite different in higher risk patterns. And we're seeing some of that in some of the real high-risk schools where we've seen some trends in suicides within some of those communities. And so there's some fundamental issues there that have to be addressed, and prevention efforts need to be put in place. Okay, I'm trying to switch to the next slide. Here we go. This just provides that information by age group as well. Okay, then trends and made a plan about how they would attempt suicide, and you can see those percentages as well. Our South Dakota trends are very similar to the national average. Again, I think we need to really keep in mind looking at that next data point to see where we're at. And then actually attempted suicide, this is the numbers that we see in that. We did not have that question in the 2013 data. I do not know if we'll see that in the 2014 data, but we'll have to just wait and see. I'm sorry, 15 data. Then the last few slides, and I'm not going to go through these, just had some information on there specific to suicide-related and suicide ideation questions within the general population, and this is data that's included in the National Survey on Drug Use and Health, etc. So that's just information that for you to look at to see where those rates are within our population. So that's kind of where I wanted to leave the suicide information. The last thing I wanted to just share, the last few slides, are specific outcome-related measures that are required to be reported annually by the Partnerships for Success grants, and not all of you are part of the Partnerships for Success grants, the coalitions that are within communities, but a substantial number of you are. And there are 5 measures that are required to be reported that are really survey-related questions that are required to be reported on the populations that you're serving. One is the past 30-day alcohol use, and one is the past 30-day non-medical use of prescription drugs, and then it's the past 30-day binge use, that is having 5 drinks or more on one occasion. And then there is the 2 perception of harm questions, the one related to alcohol use, and then perception of harm of use of prescription drugs for in ways that not prescribed to them, and that they took only for the experience or feeling that they caused. So those are the 5 kind of indicators, community outcomes that must be reported annually by each of the Partnership for Success grants. The state is also requiring all other coalitions to also report these measures beginning in FY17 as part of their needs assessment data and other reporting data. Then there are 2 kind of population-based data that come from crimes, and these are crimes that you can pull out of by county that can be pulled out of the Uniform Crime Report. There's data that the Attorney General collects annually, and they put out a report that shows this information by county and number of arrests, and so that information is to be reported as well. And then also emergency room visits by individuals that are related to prescription drug use or abuse is also required reporting measure. And so with that, you have to partner with your local emergency room to pull that information out. I hope this is kind of giving you a good indication of the kind of some of the substance abuse indicators and trends within our state. I'm sorry for the format. I prefer a more direct, interactive one, but hopefully if you have some questions, Dodie, how about if I turn it over to you to kind of facilitate question and answer session?
Okay. So if you have any questions, you can type them in the chat box, or I can see if I can unmute you. Just let me see. Oh, that doesn't work. Looks like we're just going to have to type in the chat box if you guys have questions for Roland.
I'm sure they're all asleep by now. So.
Maybe. So Roland, I couldn't remember. Was your contact information on one of the slides at the beginning?
I do not believe. I think I just had my name on there. I don't think I had it on the front.
Okay.
No, I did not have my email address on there.
Well, I can sure just, send them that information in case they do have any questions going forward. Did you point out and I may have missed it, did you point out the South Dakota, where you keep your data on the suicide prevention?
I didn't put the link up there. How about if I send that to you, Dodie, and you can send it out? And I did see a note from Amy.
Okay.
That other data source that I mentioned was the Helmsley Foundation. They did a behavioral health survey of the state, and in conjunction with Oregon Health Sciences University, and that is on their webpage at the Helmsley Foundation. And so, Dodie, I'll get that link, and I'll send you an email that has my contact information in it, and the link, the web link to the SEOW web pages, and then I'll also put the link in there for the Helmsley Foundation data, and then you could send that out to all the participants.
Okay, that sounds good. And then we have another question. Did you see that, Roland?
Not yet. Hold on. Let me see.
Says, was suicide among individuals 15 to 24 listed as the second leading cause of death or the third?
It would be the second leading cause of death. Hold on, I'm going to flip to that. Let me just see if I can't flip to that so it's on the screen in front of us. Here it is right here. So individuals 1 to 24, and this comes from the State Health Department, ages 1 to 24, it was the second leading cause of death, as well as it was the second leading cause for death ages 25 to 34. And this is in the 2013 year is when it was from the State Health Department. I've seen the 14 numbers, and they're very similar. It doesn't fluctuate too much.
And then she commented that she's found recent literature that states that accidental death is second and suicide is third.
Yeah, and that may have been in the most recent one. their health data. So again, you have to look at the numbers 13 and 14, but it could be related to that.
Okay. Well, it could also be too that the data set that was looked at would have been U.S. compared to South Dakota, right?
Sure.
National. Yep, she looked at the national data, so.
And Ashley put out there the South Dakota Suicide Prevention at Work Behavioral Health data. That is actually our data, the SEOW data that we put out there. So thank you, Ashley, for posting that.
Oh, all right. Any other questions?
I'm surprised people are still awake and asking questions. I wouldn't wish this on anybody to spend long on a data presentation on a webinar.
All right. Well, thank you so much, Roland, for presenting today. And if we will send out the other information that Roland talked about here a few minutes ago. And if you have any questions in regards to any of the other SAPs that we have coming up, just send me an email and I will respond to them as soon as I can. So with that, thank you everyone for joining and have a great week.
Thank you.